All right. Thanks, David. And good morning, everyone. Welcome to day 2 of the conference. I think David summed it up beautifully. We had a great day 1, and we hope you found it as energizing as we did. From the keynote presentation to the panel, engaging networking, plus the exhibitors. It really is a clear reminder of the innovation, dedication, and collaborative spirit that really defines this community. So I'm not going to keep you from this panel that we have. It's a tremendous panel, but I will ask and encourage you all to keep exploring, questioning, and connecting. Let's really continue to learn from each other and build toward a future where safe, effective, and accessible digital mental health is not just a possibility, but a powerful ecosystem that David said. So again, thank you for being part of this journey, and let's make today another impactful day. So going to our first session, we have convened a remarkable panel of experts that will discuss the recent events with the newly established HCPCS codes. So if you're not familiar with them, you will be familiar with them by the end of the session. Also talking about how to navigate the current regulatory and reimbursement landscape. Moderating this session is Dr. Trina Histon. Many of you know Trina. If you don't know Trina, then you haven't been in digital mental health too long. Trina is phenomenal, and she is a strategic advisor and clinical enablement expert. She previously was the vice president of clinical product strategy at Wobot, and she is a senior principal consultant, at Kaiser Permanente. So with that, I would like to introduce Dr. Trina Histon for her to start the next session. So again, welcome everyone.
Hi, Lisa.
Hi.
Thank you to you and David, and I look forward. And Mona, thank you and welcome, who's our interpreter as well today. So we have a very exciting panel lined up today, and I'm hoping my cohort of panelists will hit enter webinar and join me. There's been a lot happening within the last year in digital mental health. In the policy front, and we're going to get into it in these next 50 minutes. In fact, we probably could spend 5 hours talking about this, but I think I want to set it up by first allowing all the panelists to introduce themselves. So if you can take about 30 seconds, and Mike, you're the first pane of that I see, to introduce yourself and kind of what your background is, and then we'll get to the rest of the panelists, and then we'll get stuck into some great questions. Welcome, everybody.
Yes, welcome everyone. Thanks, Trina, so much. My name is Mike Pace. I'm an independent advisor and consultant in the health tech arena, and have been a longtime advisor and consultant to a number of digital health companies. Spent a large number of years in the pharmaceutical end of health tech and gravitated into the digital end of human health advancement in the 2019 timeframe. Prior to founding my consulting company, I was fortunate to be the head of market access and health economics at Paratherapeutics, one of the earlier prescription digital therapeutics manufacturers, and at the time operating squarely in the middle of digital mental health treatments as well. So it's a pleasure to be here. Thanks, Trina.
Love you, Mike. Jeff, you're next on my pane of the gallery that I have the folks I see.
Oh, hi, appreciate that. Hi, everybody. Nice to meet you. My name is Jeff Abraham. I am a partner and lead for the digital health practice at Health Advances, a healthcare strategy consulting firm. My background, I started out actually as a physical therapist, as a clinician, and then went into global market access and commercialization consulting, focusing mostly on medical devices and diagnostics and a little bit on drugs. Then went to work in the same area in drug device combos, and then started working in digital health almost 9 years ago now. I was the first head of market access and trade for Achille Interactive. I was their second head of commercial, and then transitioned over to to consulting about 5 years ago. I do a lot of work with a lot of organizations like NCPDP, AHA, things like that, all around digital health and mental health technologies.
Welcome. Delighted you're here. Christina, you're next on my gallery as I look across.
Hello, everyone. I'm Christina Strogis. I am the Director of Health Policy here at the ERISA Industry Committee. We represent large employers or jumbo employers on their employee benefits plan. I primarily cover healthcare and also have spent a little bit of time on Capitol Hill prior to my role, and also was the Executive Director of the Direct Primary Care Coalition, a very innovative value-based care model. So excited to be joining with you all today and kind of discussing more so of the environment in Washington, D.C.
Awesome.
on mental health. So I will, I guess, pass it along to Aubrey.
Yeah, Aubrey, bring us home. Strong finish.
Thank you. It's so great to see everybody. Good morning. I am Aubrey Shick, and I'm going to start with not my current role, but my prior role, where I was a senior digital health advisor at the FDA's Digital Health Center of Excellence, where I sat on the policy team doing development and interpretation of the policies that govern software that's legally a medical device. So any software, whether it's on your mobile app, your VR headset that's intended to treat, diagnose, cure, mitigate medical conditions, was part of our purview. I also was on the outreach side of things there. I have, given the kind of current climate, I've departed the agency, and I am now a principal consultant at Liquid Amber, working with Acacia Parks, for those of you who know her. And prior to my 4 years at FDA, I was in industry developing largely digital mental health products.
Well, welcome everybody, and just the wealth of expertise here is so impressive, and I'm really glad that we're going to have this conversation today. You know, I think if we cast our minds back to last November when CMS announced the finalized coverage for digital mental health therapies, I know many of us on the phone probably submitted comments to CMS in terms of what they should cover. And now they went live on January 1, and we're now in June. Kind of what do we think the impact of clinician adoption has been on these digital mental health tools, given we now have codes, and what challenges remain? And Jeff, I might start with you in terms of your perspective on the codes and kind of what you might be seeing with your lens.
Yeah, sure. And as the panelists and Trina know, we have access to a pretty large coding database. So just out of curiosity, we decided to pull the codes for the digital mental health technologies to see what their utilization was. And as expected, it was pretty small. It was actually really small. Out of a few 100 million covered lives, only about 200 to 300 instances of the codes being used showed up. And I would say, for the DHMT codes, I'd say the majority of those were actually, if you're not familiar with the codes, there's G0552, G0553, and G0554. 552 is a supply code to cover the cost of the product. 553 and 554 for interactive review of the data, communication, things like that. The 553 code was used a lot. The supply code was used very, very little. Now that's partially because it might be because the reimbursement is a little small for what people would like to see it as. And the other thing is as I'm sure other panels will jump in, it can be very challenging to get doctors to change their practice patterns and to get doctors to adapt to new technology. And then on top of that, the billing around it, that can be a real challenge. But we'll dive into that more later. But even in the RTM space, if you can go to the next slide, Trina, we pulled this data last week. If you look at RTM, which does allow for a review of CBT products, remote therapeutic monitoring to cover CBT, that is that small little sliver that you see at the top that doesn't actually have a number attached to it. So even when you go across kind of other areas where there are digital health coding and mental health is called out, it just really hasn't picked up on adoption yet.
Great, thank you, Jeff, and thanks for pulling the data. So Aubrey, I kind of turn to you. You know, clearly CMS pointed directly to FDA clearance as being sort of the first wave of tools that could seek to apply these codes. You know, and for many, I think the FDA process may feel a bit like a black box. So, you know, what's your sense if anybody on the call is in a startup and they are thinking about their journey and where they might fit, and then they're thinking about these codes in particular as a potential reimbursement pathway? What are some of the things you think about from, you know, your prior experience that people should be looking at more deeply at?
Thanks, Trina. I mean, as folks are developing products in this space, I think it's really important to consider the entirety of the landscape. So a lot of folks, they look at the competitive landscape, who are they being marketed against, but also looking at the authorization landscape and what product codes currently exist. There are a lot of misunderstandings currently in, I think, in the digital mental health technology space, that there's perhaps not a good understanding of how to assess a something that's using large language models or generative AI. I think it's really important for folks to know that the FDA has authorized over 1,000 AI-enabled medical devices starting back in the 90s. We also have the predetermined, and pardon my wheeze, I'm still kind of getting past it. The FDA also has the predetermined change control plan guidance. So it is possible to for the agency to approve changes and the strategy for making sure that those changes are still maintaining the intended use and safety and efficacy. And so I think the thing that's really important for folks to know is that there is a way to bring these technologies to market. It's also important to know that FDA takes a risk-based approach. So the agency is specifically focused on device software functions, so software functions that meet the definition of a medical device and could pose a harm to a patient if they were to not function as intended. And so sometimes that winds up being very focused on the indication. So a device software function with an intended use to help manage suicidal ideation versus a device software function with an intended use to help you manage your dark thoughts while you know, dealing with daily living are going to be thought of very, very differently and assessed differently. So I'll go ahead and pause there.
Yeah, no, that's great perspective, and I think you know, there is a lot of movement now with the FDA, as we're seeing in the current under the current administration. So the frameworks are out there, and you know, people should be sort of pointing toward them and also having conversations with the FDA. I think people might be afraid to go and have conversations.
Yes, that's it, early and often with the FDA. So, but don't show up with your data already collected. Definitely make sure that you've spoken to the responsible review team ahead of time. I just wanted to make sure to get that in there.
Thank you for that. And of course, you know, the CMS codes are pointing to that particular FDA clearance. But as we saw late last month, the Peterson Health Technology Institute published their review of digital solutions for anxiety and depression. And Mike, I'm going to kind of call upon you. So that is a different market, a different sort of set of lenses that they were looking through, which included FDA cleared products. But what's your sense of what Peterson adds to this conversation around pathways toward reimbursement for companies that may or may not be on a path toward FDA clearance?
Yeah, thanks for the question, Trina. It's a really important one, I think, for this audience and so many others, even outside of mental health, for sure. Health technology assessment bodies, or like I think PHTI would consider itself or describes itself as, are really important bodies to have a look at evidence and impact of technologies, for sure. And PHTI is not the only body that has a look at these types of things. And it is incumbent upon all stakeholders in digital mental health treatment to pay very, very close attention. And not only that, to collaborate really, really closely on ensuring that the frameworks with which, the lens with which health technologies are being assessed are really fit for purpose for the technology. AI is a great example of that. I was a part of the first ICER assessment. Reset-O, the prescription digital therapeutic for opioid use disorder, was the first PDT, first mental health treatment device, the first prescription digital therapeutic for a mental health condition that underwent a health technology assessment in the US. And it went through that assessment with an assessment body that was used to assessing drugs and not mental health devices. PHTI is in the unique circumstance where its primary constituencies are more so employers, but also health plans as well. So the point of view and the angle of the assessment, I think, is very important for folks to know. I think what probably many in this audience know, or they will know once they go read the report cover to cover, which I would recommend everyone do. I would recommend everyone in this audience do. But that report for virtual solutions in anxiety and depression was it's a milestone one, and it really paid tribute to the clinical effectiveness and positive economic impact of the many form factors that digital mental health treatment devices and digital treatment devices themselves can deliver. So self-guided solutions, FDA authorized solutions, blended care solutions, all came through this somewhat unbiased or meant to be unbiased point of view with some favorable light shown upon them in many circumstances. But what I would also say is this is just a moment in time. And I think the biggest takeaway for an audience like this is moments in time should spur action. And the action to me for access to digital mental health treatments of any sort requires a number of things. It requires demand to be understood and to be appreciated by stakeholders. It means that advocacy efforts must be undertaken collectively to make an impact. And also, and very much, PHTI underscores this, evidence is required to support the solution. And Jeff, I'll come back to you on the great, thank you for sharing the claims data for this audience as well. But it's disturbing to me to see the supply G code of a digital mental health treatment device be so painfully small in its request for reimbursement to CMS. And that needs to change in order for this industry to generate the type of momentum, demand, advocacy, value momentum, because in the absence of payers actually seeing the industry seek claims for what they believe are valuable tools and mechanisms for patient outcomes doesn't bode well for policy change as well. So I'd leave it at that.
If I can just jump in, Trina, I was just going to say from an employer standpoint too, these reports that PHTI has put out are more so appreciative from the employer lens. And this recent report is actually very positive in its results, but employers really pay attention to these as well, and more so in implementing them within their employee benefits design for either this year or continuing into the future, or implementing them again into the next plan year. So these are, I'm very happy to see this PHTI report as well. I know that a lot of the employers are excited to see the results of these, and more so the uptake is occurring, and hopefully, like you said, Michael and Jeff, hopefully the coding will progress as well as more uptake occurs. But go ahead, Trina.
Thank you, Christina. Yeah, I mean, I think they offer a blueprint for what the bar looks like now, and what are the dimensions of measurement, and sort of how your product is meeting a particular need for this was focused on depression, anxiety, but I think it's really important, as Mike and Christina said, like, read that in depth. I mean, there are summaries to read, but go through things, you know, with the fine-tooth comb, because I think it shows where the metrics that matter are at this current time. So, you know, David and Lisa in their opening remarks and today and yesterday spoke about an ecosystem. So how can industry and other stakeholder groups best plan ahead? we're clearly in a time of high volatility and uncertainty about policy changes in the pipeline. And, you know, decisions we make today might impact in a year's time when you're in a company, or obviously if you're doing science, that takes time, or if you're in academia and, you know, you may or may not now have that grant you had, that takes time. So how can we best kind of plan for, you know, the volatility that we're living through? And Mike, you know, I'm actually might start with you. Like, we know that there's a bill, I guess it is called the Big Beautiful Bill, colloquially going through. What are the implications for that, and how can we be ready for where some of that might land?
Don't we wish we all had that crystal ball? We're all feeling this one together, and you don't have to be on Capitol Hill, obviously, to feel that. But speaking of Capitol Hill, I think one of the things I would suggest is, I feel as though my experience in this industry is that policy change in mental health or in healthcare in general is not necessarily a national issue. Um, and while I think it feels as though there's some signals and there's some bureaucratic documentation in the MAHA movement that would suggest that there is an appetite and an embracement of digital health solutions to be supportive in both integrated care, behavioral health care, and preventative medicine, and really leaning in, I think, to what many of us in the digital health field have hoped to see administrations and see policy start to reflect on. We know that there's a request for information and hopefully a really strong openness and consideration of industry comments upcoming to CMS in this regard. But I guess maybe others can chime in, but I think it is an opportunistic time with both administrative change, both the narrative coming from Capitol Hill, and frankly, what we're seeing in the Big Beautiful Bill itself as being a real tremendous risk to the most vulnerable populations that so many in this audience and beyond, that their life's work has been about preserving mental health. And right now, we're on the precipice of seeing the most vulnerable populations be dramatically impacted, not in a positive way, from resource and from access to care, almost a reversal, right, of what we've done. And I think it truly is the burning platform for this society and for all related organizations to use this as the opportunity, the burning platform to once and for all, and it's very timely with PHTI and otherwise and digital health codes, to say we have the evidence, we have the requirement, we have the moral imperative. And by the way, we now actually have a mechanism by which we need to make better human health occur as a result of leveraging these things. So I would just encourage everyone to be on Capitol Hill, but also be at state capitals, making sure that this is well heard. And I know there's a whole bunch of people at ATA Action, for instance, that'll be on Capitol Hill tomorrow, supporting some current legislation around digital mental health and PDT specifically.
Great perspective, Mike. And I was struck by when I read the MedPAC notes from the April meeting. There still seems to be a lot of confusion about what a digital mental health tool is. And Aubrey, I'm wondering if I can call on you and experience that you've had recently. Do we feel like the baseline knowledge of what these tools are and how they can add value is at a high level? So as different stakeholders talk to different people, are we all sharing the same information, or do we still have an educational hill to climb based on the experiences you've been having in conversations locally in Colorado?
Thanks, Trina, and thanks for framing that. And yes, I'm based in Colorado, and I had the opportunity to attend a post-legislative session recap, where some of our representatives and senators were there, and I obviously kind of asked some questions about the digital mental health technologies and opportunities, and it became clear very quickly that there's still a bit of a fundamental misunderstanding of the differences between telehealth and digital mental health technologies. And so while they are very, very passionate about advocating for the rights of some of the marginalized citizens and the impact on the communities, especially in this mental health space, this lack of understanding of what resources may be available is still very much a hill to climb, and how those may be accessed. Whether you need high-speed internet, for example, was something that was a concern, because again, it's all kind of being aligned with this kind of telehealth. And so, I'm speaking specifically to Colorado here. Something that I really want to drive forward, and also echo a bit of what Michael said, is there's a lot of opportunity right now. So there's a lot of things are changing, but this is a time to reach out and influence. Like many things are changing. And so make sure that you're contributing to educating, to bringing awareness. What I can say as someone who has, recently departed government is it's very, very difficult to push really great, well-developed ideas forward from the inside. There must be pull from the outside, and so it would be best if we, as industry and patients and stakeholders and Americans, are kind of pulling forward what we need to allow all that great work on the inside to come out.
Great point. I think time to act is what I'm taking from this conversation, and that we, in the seats we sit in our companies or in our roles, have a voice, and acting locally is important. Christina, I'm wondering, again, also policy changes and implications of, say, mental health parity on the employer side. What sort of kind of popping up for you around again, this period of uncertainty and volatility, yet people needing services and needing support.
Yeah, definitely. And I was gonna piggyback off of what Michael and Aubrey have said, and want to also remind people too that um, with the budget reconciliation process, there are very strict rules, and especially it's called the Bird Rule, and I'm definitely not going to explain. Sorry, I'm not going to go into detail exactly what that is in regards to parliamentarian decisions in regards to what stays in and what stays out in regards to budget reconciliation, but it has a lot to do more so with her determination, and only certain policies can be included within that. So there's a lot of things that, again, that's part of the reason why there's a lot of focus on Medicare and Medicaid at the moment, is because it fits within those budget reconciliation rule processes. And while there are things that the employers would like to see done in regards to, not related to mental health, but more so like pharmacy benefit manager transparency and reform, it just it just will not be a part of the budget reconciliation process because it will likely be stricken. So budget reconciliation is very complicated, to say the least. But there are from an ERIC member standpoint, we would really like to see movement on improving access, especially in regards to Capitol Hill. From when I started back with ERIC, I know back in actually 2020, there was COVID really brought about the ways to improve the digital mental health landscape, and especially through telehealth as well. And I will try to put this in the chat for everyone, but we have put together, and maybe we'll share at the end, but we put during COVID, we were having discussions with employers on what they're seeing with their employees in regards to mental health and how we can help. So we put together a top 10 solutions for Congress to consider. And unfortunately, Congress during the COVID time missed missed a large part of the boat, large part of, yeah, large more part of the boat, I would say. But there's still more that could be done, and especially allowing more so a national, like a national allowing mental health providers to practice across state lines to improve access to care, or rather having a national policy compared to having state compacts. State compacts are very helpful, but from an ERISA standpoint, the employers would really like to offer telehealth to, like, say, someone in Delaware to also having that benefit to someone in California too. So having it more so nationally will make the employers very happy, and I'm assuming very much so the patients as well, especially while they travel. And also a part of something we'd like to see get done as well is more so offering a digital health solution to an employee that isn't necessarily on the employee benefits plan. So this could be, for example, a part-time employee, someone that is on their spouse's plan, or even an intern that is just kind of like starting out in their career. And again, trying to promote access on Capitol Hill is part of our focus for ERIC as well. And I'm happy to share the report, because we do also need more mental health providers as well. So we part of our top 10 solutions is to have incentives more so to gain more mental health providers as well. So we know that is a part of the conversation, as well as having that communication between the provider as well as the insurance carrier of whether or not the provider is taking new patients. That's a big thing as well that we'd like to tackle. So we have a lot of aspirations, I would say, from an ERIC's policy standpoint, and trying to improve the digital mental health landscape. And really, although budget reconciliation is tough, I'm hoping that with this upcoming September package, that there is more room for conversations on improving healthcare for employer-sponsored insurance, as well as for those not on ESI as well. So there's more to come. But then again, I can't stare into my crystal ball in regards to what September will bring, unfortunately.
Well, it's sounding like from all your comments, like there's a lot of opportunity, and an opportunity to educate and have a baseline level of knowledge, but also the importance of tailoring the message to the audience and giving those who can move policy forward a deeper understanding on what's needed. And as Aubrey said, it's not going to come from within, but really educating them and detailing them with policy briefs, etc. But in the language they understand. So there's an opportunity, there's translation, and there's education from what I'm hearing. And panelists, I'm going to kind of flip our questions a little bit, because I think this lends nicely to the fourth question we had. And if you have questions, please put them in the Q&A. I know we've got a couple in there already, but feel free to put those in. So, what are the differences that we're seeing in things that are happening at the federal level regarding, say, regulation and around digital mental health, and then what is happening at the state level? So Mike, I wonder if I'll call on you first around kind of what you're seeing around that. And it's almost like think globally, act locally is what I'm taking away from this. But what are some of the things you're seeing?
Yeah, I mean, there's a lot going on in state capitals as much as there is in DC. It's just that the echo chamber is, of course, in DC, so we don't hear as much, particularly when you're in one state. You don't hear what's going on in other states unless you're like very, very actively listening and integrated. So, I mean, obviously, the behavioral and mental health landscape on at state capitals is being, largely spoken to by various constituencies as well, focused on, access and telehealth extensions as well, access to care, payment as well, reimbursement, like all of this, the same kind of issues. I think one of the things that just continues to stick in my mind and is troublesome but is solvable, is this one where, Medicaid, for instance, which is such an important program to the mental health community, and so many diagnoses, DSM diagnoses, are sitting squarely within the Medicaid population. And often, I think even in the largely educated and professional behavioral mental health community, um, we largely think that there hasn't been a strong pathway for digital mental health treatment devices, digital devices themselves, to be reimbursed through standard covered benefits within Medicaid programs, as an example. Um, and we've been fighting to say Medicare, right? The halo effect benefit of America. We need to go and enact legislation on Capitol Hill in order to unlock really widespread benefits and access for patients in need. And the reality there is that's not the case, right? And often history is now becoming exactly that, and we're not necessarily recognizing the fact that multiple state Medicaid organizations, after a lot of effort by colleagues and friends and supporters along the way, chose to cover the first prescription digital therapeutics in their state Medicaid programs through standard healthcare benefits. They use the pharmacy claim system. They build it through their standard healthcare benefits. And we saw these things happen in multiple states, and many have heard Massachusetts and Florida and Oklahoma and other states being very much on the precipice of this happening before that organization unfortunately went bankrupt. And we need to strongly remember that uh, all states can actually cover these types of products today. Um, and what's held them back is kind of the uniform guidance and the uniform structure and the kind of the yes, as opposed to you need to come and ask me just to confirm mentality. Meaning, for a long time, there's been simple asks for state Medicaid guidance out of DC, for instance, to reassure state Medicaid directors that if they covered prescription digital therapeutics for mental health conditions, that somehow their financial match from the federal government wouldn't be there. And so it's very hard for administrators and state capitals to go to their Medicaid director or their Medicaid director to feel comfortable going to the governor when there isn't certainty around such a thing, right? It's important to taxpayers of the state. So I make that just simple point today to say, don't let history be that. Let that be the teacher of what can happen today. And let's recognize that while legislation's on Capitol Hill and why advocates are here in the room and on the phone and can take action in both of those places, let's just recognize that there's actually some low-hanging fruit that can be capitalized on today, and that we shouldn't lose sight of the fact that it's kind of like separating the trees from the forest, so to speak. And while we know there's still a long way to go as it relates to supportive reimbursement and coverage for behavioral and mental health treatments, there actually is a whole bunch of pathway that isn't fundamentally being utilized optimally today.
Yeah, Mike, and if I could follow up on that, Trina, I think looking at even kind of atypical funding pathways, what California and like Pennsylvania did with Couth, kind of agnostic of maybe the success of the program, which is debatable. California set aside hundreds of millions of dollars literally for mental health treatment. And what was nice was that Medicaid was able to cut through the red tape of commercial insurers will sometimes be like, especially with children, that some mental health conditions are the school, some are part of the psychiatry world. It kind of are counselors. It really varies back and forth, and it can kind of be a ping pong ball. Coming from Achille, where we're working on pediatric ADHD, and the state Medicaid programs just cut through it, and they're like, no, we're gonna fund it because it's worth it and it's the right thing to do. And I think what's going to be interesting is we obviously see hundreds of billions of dollars in potential Medicaid cuts, which I don't think anybody in healthcare agrees with, quite frankly. But that being said, I think what we're hearing from a lot of our clients and a lot of technologies outside of digital as well is what do you think the state Medicaids are going to do? How do you think it's going to work? Like, are they going to say no to innovation, or are they going to look to innovation as their salvation potentially? And I think I think right in the near term, it'll be a little helter-skelter. Like, I mean, I think it's just reality. Aubrey, you've worked in government for a while. Like, it can kind of be a paralysis, I think, when there's a lot of change, but eventually it does settle down. And I agree with Mike. Like, you should be looking at this at a state level as well.
Thanks, Jeff. I'm going to move us into our last question because I'm conscious of time, and I know there'll probably be a lot of questions coming in as well. But again, pulling through, this is a big time. This is opportunity. We all have a voice, and it's time to, maybe go to state capitals as well. So kind of leaning into that, what are the biggest changes that are happening in the digital mental health regulations, given the current political climate? Like, what, again, no one's got a crystal ball, but certainly seeing a lot more movement, say from FDA and other groups, even at state levels, in terms of thinking about, around AI and policy around AI. But, what are we seeing as some of the big movements since the new administration has come in? And Aubrey, I might start with you, given you've been the most recent person in the administration, in terms of, where's the FDA kind of moving toward, and what are they more open to now?
I mean, I can try to do my best here, but it's, knowing kind of how folks were thinking at their desk versus what finally goes out the door is another thing. So I just want to, caveat everything here. But I also want to go back to something I said earlier. Around FDA really takes a risk-based approach with these digital mental health technologies. And there are a lot of solutions out there that may be tremendously impactful for people with mental and behavioral health conditions, but that are not maybe as high risk as some others. And so in some cases, we may be, as an industry, there may be some incentives around the reimbursement and such, to push products into this higher risk space that is just much more burdensome to bring to market. I want to point out that during the COVID mental health crisis, there was specifically a digital mental health technology guidance, which has since been sunset. But I think, to the best of my knowledge and awareness, there were no adverse events related to that policy. And so, the important takeaway here is, how can we, with a kind of right-sized, oversight, bring beneficial mental health technologies to market in a way where they are covered and access is being expanded, while at the same time we're reducing some of the burden on the agency. Like, there are a number of instances where it doesn't make sense for the agency, for some of these products to be the focus of FDA's oversight. And another thing I think that's really important to clarify here is, just like no one medication is going to be right for everybody, no one digital mental health technology is going to be right for everybody. But for that subset of people, it can be life-changing. And so it's really important to drive that whole picture forward, along with that kind of risk-based perspective. And then back to, what are the things I want to kind of encourage folks as we're moving forward. We need to ask for clarity and transparency around how some of these different, AI, digital mental health technologies, some of the virtual medicine stuff. There's a lot of great work that folks are doing that we need to be calling and asking for that transparency as an industry to help move it forward. Because right now, at least my most recent experience, nothing is going to originate on the inside right now.
Great feedback. Any other comments from the other panelists before we move into Q&A?
Yeah, I think, sorry. Go ahead, Christina.
Oh, I was just gonna say too, since May was Mental Health Awareness Month, I know that Secretary Robert F. Kennedy did meet with a variety of different stakeholders for that month. I believe some videos are on his LinkedIn page, but employer groups were one of them, and Eric's president and CEO was able to sit at the table and discuss some of the report that we put together with our top 10 things that Congress could do. From a HHS perspective, I am happy to report from that meeting there does seem interest there to do a national digital health / telehealth policy. So as Aubrey has said, I think in more so engagement as well, on for at the congressional level as well as the state and local level, because all politics is local, and also engaging with HHS is very important at this time to potentially move forward in actually getting a policy. So I just wanted to add that news in, because it does seem as though our advocacy is working. So I'll turn it over to Jeff.
Yeah, and I think going back to the national level, thank you, Christina. I think a lot of us have seen that CMS, along with I have to read this because I won't get it, the Assistant Secretary for Technology Policy, and the ONC, which is the Office of the National Coordinator for Health Information Technology. That one I think I got off the top of my head. They put out an RFI with CMS. And I think that's actually hugely important. And to Aubrey's point, it can be a little frustrating. And this RFI is asking about, like, I think the patient, provider, payer perspective of how to work with digital mental health or digital health technologies. It can be really frustrating to us that have been in the industry for a while, that we have to kind of constantly keep repeating that is what it takes. And until a year or 2 year or 3 year period, you can go from that point to you've reached your goal. You're going to have to keep doing it over and over again. That's just the way that it works. But it is really encouraging that they're reaching out. And I think before we get to the question, I think one of the things is that some of the stuff that we have to do to make it successful from a policy standpoint is stuff that people are not going to find bright and shiny. It is about data interoperability. It is about access for payers and providers to get that information. There are a lot, and kudos to Society for Digital Mental Health. They'll be joining NCPDP as we work on those things. But like, that's really important as well for the policymakers, because they will sit there and be like, okay, I get the product, but now how does all this work? How does somebody actually use it? It's really important for us to remember that every business that has a product is a customer service business. So we're not just a set of products, we're a set of services as well. And our customers and our end users are all important.
I have a really important thing that I want to say about these RFIs, which may not be obvious. Back to what I keep saying about these things can't originate on the inside. If an RFI goes out and then industry asks for what has been worked for, what folks have been working on the inside, it then becomes very easy to deliver it. It's a very important mechanism right now. Respond to those RFIs, because they can be like, oh, it came from the outside. It came from the outside. This is the time.
Okay, I think, you know, we know this is a marathon, not a sprint, but I think these opportunities are now in front of us. And Bethany, I might ask on you to see if we can find the link for the RFI so folks have it. I know the deadline is sometime this month. I should know it off the top of my head, but I want to open up. So thank you all the panelists for just really, I mean, I'm trying to remember all of these wonderful points in my own mind as I'm listening to you all, but what questions do folks have? Thank you, Jeff, for putting that in there. So that link, go grab that link, and then post-conference, because I know you can be busy for the rest of the day, go in there and you know, put your perspective in. If you're the company, you know, get together with your teams to have a response, you know, from your company, because they're asking, and these moments don't come along very frequently. So, Mike, I think there was a question directed to you that you're going to answer live. So we'll take that first question that's in there around evidence, and then I would ask for others to put their questions in, so we can get to those before we close.
Sure. Very quickly, there was a question from Eduardo, and the question was, evidence is needed in mental health tech, but the process for getting evidence-based practice is pretty steep. What resources or avenues do you recommend for getting to that evidence base, especially given that research funding might be on the chopping block all around, especially at NIH, right? Another one of those policy issues going on. What can we learn? Blah, 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 blah. Keeping it very, very brief, I personally, and in my experience with employers and with clients, I am a massive believer that tokenization is tops. And if organizations fail to take advantage of the simplest, most important first factor, which is ensure you can always track the potential good and bad that might happen with a user, you've already lost. And if we're talking about the most efficient, I won't necessarily say effective, but I will say useful, but the most efficient and at a minimum useful, if not effective evidence generation starts with that. And it starts with being able to monitor. So I'm a big believer that much evidence generation to support evidence-based practice, to support the value of mental health treatments starts with the de-identified linking of real-world data. And it starts with, particularly in this area, it starts with the wonderful progress we're making in mental health digital diagnosis and biomarkers, moving into remote monitoring capabilities and into digital treatments and ongoing management. We have a full spectrum to look at the entire patient journey in a meaningful, data-driven way, but it always starts with tokenization.
Thanks, Mike. Not seeing other questions there, and Bethany, you can tell me if I'm looking in the wrong place, but I don't think I am. In our closing moments, we talked about in our prep calls a call to action. So I want to give each of you one sentence. What's your call to action in this moment, given the richness of the moment we're living through and the volatility? Jeff, I'm going to start with you.
Oh, son of a biscuit. One word. Well, not one word. I can't ever do that. I would say, don't be discouraged. Fight on. Just because it seems like in some ways that it's a lot of uncertainty and it's very unsettled. This is not a bad environment to keep pushing this forward. The agenda is moving, so keep doing what you're doing.
Thank you, Jeff. Christina, one sentence for.
Yes, stakeholders' voices are extremely important in the conversation, so keep at it. And as Jeff said, don't be discouraged.
Great. Aubrey.
Keep asking for the transparency and the clarity, and propose what that information is. Ask for exactly what you want to see. Ask for, confirmation, for access, and that's the path to getting it.
And Mike, you're going to bring us home in about 30 seconds. What was your call to action?
Ask for help from everyone around you, 360 degrees. In this area, I've yet to find anyone that says no. The people that we need to say yes, still, we might have a lot to do, but we'll have a better opportunity for them to say yes if we ask everyone else for help. So please ask everyone for help.
Yeah, they can't ignore the cacophony of those doing the work. So thank you all panelists. This was an incredibly rich discussion. We are at a very important moment in time. I look forward to when we come back next year to seeing where the progress is. The codes are out there. They're not well used yet, but we're going to learn a lot. So thank you all for your time today, and enjoy the rest of the conference.